One of the biggest fears that most junior doctors have when they make the transition from being a medical student to starting your junior residency program is about resuscitation. You get your first call day, you're called by maybe the sister, the nurse that's taking care of the patients, or maybe even the relative comes in screaming, looking for you that the patient is gasping. And in your mind, you literally freeze up. Even when you get there, you freeze up. You won't know what to do. Moreover, if you're dealing with other people that also are rather relatively new, then that patient is doomed. So I really thought it was quite important that I do a video on resuscitation. What should you actually do when you are resuscitating a patient? How should you work through it? How should you go through it? What is your mental train of thought when you're performing this resuscitation? Because this is going to help quite a number of people. It is going to be one of many videos. I am actually going to be getting an expert paramedic to actually feature on the channel very soon. Hold on for that video very soon, but I wanted to do this preliminary video to just get this out of the way so that you have something at the back of your mind, something that's lingering and will help you throughout your career. So grab a piece of paper. Let's talk about resuscitation. Let's go. Hello and welcome to MK's Medical Review Series. My name is Dr. Moses Kazevu. This is a series of my YouTube channel where we look at medical topics in depth. Today we're going to be looking at resuscitation. What should you actually do in that particular incident when you're called to review a patient that has changed condition? What should you do? So remember that your goals of you resuscitating the patient is for you to actually maintain their cardiovascular and pulmonary activity, because as long as you're performing effective chest compression, blood is circulating in the body, you're ventilating this person quite all right, they are oxygenating quite all right, their tissues will not begin to die. Immediately you stop your chest compressions, you stop your ventilation, and you haven't yet addressed the underlying cause, this patient invariably will die. The second thing that you're aiming to do is to address the underlying cause. Remember that resuscitation in itself will not address what caused this patient's heart to stop. It will not address what caused this patient to stop breathing. Maybe they are bleeding from somewhere. You have to compress that. You have to suture that bleeding. Maybe they had a pneumothorax, you have to address that. Maybe they had a myocardial infarction. Maybe they had a pulmonary embolism, you have to address those. Because as long as you haven't addressed the underlying cause, this patient is going to arrest again, and most likely they will die with the next arrest. Or if you do save them, there will be some significant neurological damage. And you also want to make a decision. When am I supposed to do the CPR, the cardiopulmonary resuscitation? When should I not? There are some instances where we're going to say, no, let's not perform CPR on this particular patient. Then there are some instances where we do perform CPR on particular patients. So you need to actually be well versed with this, because you as a doctor, you're actually the team leader and you're going to be the one that is directing everyone, and everyone is waiting on your orders. So generally, throughout this video, I've divided it into 3 parts. The first part is just simply dealing with the basics, the components of resuscitation, when we resuscitate patients, when we don't resuscitate patients, what initial assessment should you walk through in your mind as you are resuscitating your patients, as you are hearing certain values from the other workers, certain vitals. What are you supposed to do? What medication should you use? What equipment should be ready when you're resuscitating your patient? I cover that in the first section. In the second section, I'll give you a practical guide. Of course, I will be mentioning some specific scenarios as to what you should do in those specific scenarios, but there will be some separate things. And then, of course, what to do after you have resuscitated the patient. Of course, if they have survived, there are things that you need to look at. What caused them to arrest in the first place? Then if they haven't survived, of course, then you have to write your certification notes in the file. So we'll begin with the very first section, which are the components of resuscitation. So there are 3 things that I want you to keep in mind here. And you have to think through this very quickly. Number 1, you want to initially assess the patient. Your initial patient assessment, very important. And this must be quick. You don't need to take more than 2 minutes assessing the patient, because actually even more than a minute is a very long time. So this must actually be done within a minute, and it must be very quick. Make your decision there and then. of course, you're going to have to call for help because you can't do this alone. In this case, you are the help that has been called. You who's arriving at the scene, you're going to be the senior most. If your senior doctor is not there, you as a junior doctor are going to be the senior most. So you're going to be assuming the role of what we call a team leader. You assign roles to people. There'll be someone who's going to be keeping track of the time when you're resuscitating. There'll be someone who'll be in track of checking the vitals. There'll be someone who'll be taking care of the airway. There'll be someone who'll be taking care of the breathing. There'll be someone who'll be taking care of the circulation. Someone who'll be taking care of the disability. Someone who'll be exposing the patient if it's, for example, a road traffic accident. Each and every single person must have a particular role. If you're in the emergency department, we actually assign these roles at the beginning of a shift so that you know exactly who's on what and who's doing what. Then you want to assess your vitals because vitals are very important. They're going to help you now determine what you should do for your patient. For example, someone comes in and they're unconscious. You quickly do an RBS and you realize that the RBS is 0.8. The quickest thing that you're going to do is give this person dextrose. You give them a 50% dextrose and they wake up. It's a wonder drug, but it's not the only thing that will cause your patient to be unconscious. Obviously, they could come in and they're unconscious or unresponsive because of various things. Maybe they've had a stroke. Maybe they have had a pulmonary embolism. Then, of course, you are also going to do your ABCs that I'll talk about in much greater detail. Then you need to also organize your medication and your equipment. There are certain things that you need to be available. The defibrillators and AEDs, you may not find them on the ward, but you will find them definitely in ICU. You will find them in the emergency ward. But you can still do without these even on the ward because your chest compressions and your ventilations are enough. I can guarantee you there is an ambu bag in each and every single ward, unless if it's not really a ward. But if you call it a ward, you should have an ambu bag available. You should have some oxygen that is available. An intubation kit, like I said, also just like with the defibrillator, can only be found maybe in the emergency ward, or it can be found in the high dependency units, or it can be found in ICU. And of course, you need a ventilator to be present. You need your dextrose 50%. You need some IV fluids, normal saline, Ringer's lactate, DNS to be available, D10, D5, anything that you're going to be using in terms of resuscitating that patient. You need certain medications, emergency medications. So drugs like antihypertensives, the IV formulations, epinephrine needs to be available, hydrocortisone needs to be available, atropine needs to be available, lidocaine or lignocaine needs to be available. Amiodarone needs to be available. Those are some of the things that you should use. When we make other videos on advanced cardiac life support, we'll talk about those drugs in a bit more detail. This is just like an overview, like the bare minimum, the basic thing that you're going to be doing for your patient. And you're going to decide based on your initial assessment. I have a patient that is unresponsive, but the prognosis of the condition is poor. Should I do compressions or should I not? The patient is not breathing, but the heart rate is less than 60. What do I do? The patient is not breathing, but the heart rate is normal. What do I do? The patient is not breathing, but and has no pulse. They're unresponsive. What do I do? The patient is gasping. The vitals are unrecordable. What do you do? These are all things that you will be called to the ward by the nurses to come and address to these particular patients. I'll talk about these particular permutations a bit later on in this particular video. So we'll begin with the very first thing. When should you resuscitate? When should you perform these resuscitative measures, these life-saving measures? All patients that are unconscious, they need to be resuscitated in some form of capacity. All patients that are unresponsive. The first thing that you must do for your patient is try and see if they are responding. Call out their name. Jolt them or shake them a bit. Not too much, but shake them a bit. Try and call out their name. This is a bit different when you're out there in the world and you're not in the hospital. When you find someone has been, for example, in a road traffic accident, if their airway is not compromised, do not attempt to maneuver them or put them in a certain particular position. Just wait there, call for help. But if their airway is compromised, then you should intervene. And if they're in any immediate danger, you should remove them from that immediate danger. But it's a bit different. Right here in this video, I'll be focusing more or less in the hospital what we do. And they could sometimes have a cardiac arrest when their heart stops or they're unconscious and they become pulseless. Most of the times, the cardiac arrest in adults could be because of actual cardiac conditions or even extra cardiac conditions. But in the neonates and the younger children, usually the heart stops because they are hypoxic, which is why ventilation becomes very important, especially in the very young ones, as opposed to in the adults. I'm not saying it's not important in the adults, it's also as important. So you should look out for things like acute coronary syndromes. Have a quick idea of what this patient was being managed for, acute circulatory problems. When you get to the scene, obviously there's a nurse that is managing this patient. Ask her quickly, what was this patient being managed for? What are this patient being treated for? Which is why whenever you have patients in the ward, you must know what each patient is being treated for. It could be a pulmonary edema, it could be a myocarditis, it could be a serious trauma. These are all the things that we do resuscitate patients for. There are many other things. The list is quite exhaustive. Then when should you not perform the resuscitation? There actually is only one absolute indication, something that is known as a DNR order, a do not resuscitate order, or if they have an advanced order for them not to be done any chest compressions on, and they know that they're going to die if they're not going to receive the chest compressions. Because if you do resuscitate such a patient, funny thing enough is that you will be sued. If you perform chest compressions and they are alive, they'll sue you. So if they do have a do not resuscitate order, and it should be like legal documents, it shouldn't be like a tattoo on their body. If it's tattoos and there's no one else there, there's no relatives, this is just like a John Doe or a Jane Doe that has been brought into your facility, resuscitate them, save them. Yeah, I think there has been such a case that I saw on social media. I think it must have been in Florida, where a patient had a tattoo of DNR and the paramedic resuscitated him and then he was taken to court. So long story short, the paramedic actually won the case because his primary role is to save the patient's life. Then there is a relative contraindication which most of the junior doctors actually tend to struggle with when you actually get into the system for the very first time, when not to perform the CPR. And you get various patients. For example, someone who's severely injured. They have been involved in a road traffic accident, severed limbs, they are bleeding, almost paper white, then they arrest. Are you really going to resuscitate the patient? Even if you resuscitate them to what? How long is it going to take for theater to be ready for that patient? How long are you going to save that patient? Are you going to spend so much resources in trying to save that patient who is eventually going to die? So if they're severely injured and you know that even your medical efforts are going to be futile, there's no need for you to resuscitate. You get a patient that is clinically brain dead, there's no corneal reflex, the pupils are fixed and dilated, they're not responding to light, and they arrest. If you bring them back, what are you bringing them back to? Then, of course, if the prospect of them coming back offers a poor quality of life relative to the age, for example, you get someone who's 80 years old, they have a massive stroke and they arrest. Even if you bring them back, what are you bringing them back to? Already they are quite old, they are quite frail, and the quality of life is not going to improve post this particular condition. So I'm not saying that this is a rule that is set in stone, that don't resuscitate people. No, you did not hear it from me, and that's not what I'm advocating for. But of course, it is a field where you can actually put in more research, and there are a lot of ethics that are considered to this. But for the patients that you deem that resuscitation is going to be medically futile and their quality of life will be very low, or the prospect of this person surviving even after is very little, then you can actually save your resources and not really resuscitate that particular patient. So what are we going to do in our initial assessment? Remember, the first thing that you're doing is you're calling for help. In this case, you are the help that was called. The sister called you, the nurse called you there. Mobilize everyone who's around that can help you. If you have students around, mobilize them. If you have the auxiliary staff, the cleaners there, mobilize them. Anyone can help you in a resuscitation protocol. You're going to assess different roles. Like I said, all these things are happening spontaneously. It's only a matter of fact of teaching that these things are happening, or I'm teaching them like sort of like they're in steps, but all these things are happening spontaneously. They're happening in real time. So one person is going to be in charge of doing the vitals. Often you can assign the nurse or a student to start connecting the BP machine, start connecting the pulse oximeter, to start taking the respiratory rate, and there'll be someone who will be checking the time. And these vitals are very important because they're going to determine some of the interventions that you're going to institute. So the first thing that you're checking, whenever someone falls unconscious or they're brought in unconscious or their heart stops or whatever, do your vitals, check the RBS, check the random blood sugar of this patient. You can have three possibilities. You can either get a reading that is low, sometimes it can even fail to read, it can be unrecordable, or it can be less than 3.5. I want to use a higher threshold than 3 because generally I work from the emergency department, so I want to use a much higher threshold of 3.5. Even in ICUs, they'll use 3.5, but even something that is less than 3, then you need to bolus that patient. So you get your IV access. Already you're instructing someone to get a cannula and insert the cannula, drawing blood for samples, and at the same time you push in your 50% dextrose. And remember that if it's in adults, 30 to 50 mils. If it's in children, we avoid 50% altogether. You can give them 10% and 5%. I'll do a different video on resuscitation in the pediatric department. This is largely focusing on adults. Then after now you have given this patient the dextrose, you continue. You recheck, you wait for some time, then you recheck. But at the same time, you're checking all these other vitals and you're putting them on an infusion of some dextrose containing fluid. Maybe it could be a D5, it could be a D10 afterwards, because if it's something that caused them to be hypoglycemic, they'll keep being hypoglycemic and eventually they may develop neuroglycopenic brain injury, worse off they can die. Then another possibility, if you check your RBS in this particular instance and you find out now that it's high, what are you going to do? It depends on why this RBS is high. Because remember, if it's a sepsis, it may cause your RBS to be high. Maybe they're in multiple organ dysfunction. In some cases, it could be a diabetic patient. This is a patient that may need IV fluid. So they may be unconscious. You do your urinalysis and they tell you that, okay, ketones are 3+, glucose is 4+. RBS is high, patient is unconscious. What's your diagnosis? DKA. So you want to start your fluids. Put your cannula, start running your IV fluids. Elevate the head end of the bed because you may not know. If it's a referral that's coming in from another facility, maybe they already gave fluids. Maybe they could have even given bicarbonate and this person has developed some cerebral edema. So you may not know in the real time. Then if it's normal, then generally there's no intervention that you're going to need for this. Then the next thing that you're doing is the BP. Someone is checking the BP and they're shouting these values. Someone is also documenting everything that is happening. If there's medication that you're giving, someone is documenting it. So they'll shout the BPs. If the BPs are low or they're unrecordable, start getting your IV fluids. Quickest one that you can go for is normal saline. So start getting your IV fluids, give them a bolus. If they're not so old, you can give them 500 mils and then see what happens. And you squeeze. You make sure that it runs in less than 15 minutes. And you are checking the BP as you are infusing this. Someone is drawing blood they're taken to the lab for the purpose of a cross-match. Because if it's a hemorrhagic shock, they're in an RTA, they need blood. If it's hemorrhagic shock, the BPs are low, you may even consider plasma expanders like Chemocell that you can actually give the patient. So you're giving your IV fluids. You push in the first 500, you recheck your vitals to see. You push in the next 500, you recheck your vitals. The BP is still unrecordable, pulse still not available. Try give them a jab of epinephrine. By at this point, the BPs and the pulse being unrecordable means that you should have already started your chest compressions as well. So BP tends to go hand in hand with the pulse. You check the BPs and you find out that they are high. You're thinking maybe this person needs an antihypertensive, but we're not so quick to dropping the BP, because if you drop the BP very quickly, their brain will become hypoperfused, then you're causing more damage. If it's an ischemic stroke, for example, an acute ischemic stroke, we all actually don't even want to drop the BPs unless if they're very high. So you're looking at your systolic values greater than 220 over your diastolic values greater than 110. If they're quite so high, you're giving them some IV antihypertensives like labetalol, like your hydralazine to actually drop the BPs. If the BPs are normal, then you may not need some intervention. The other thing that you're going to be considering now is your pulse. You feel for the pulse. And remember, do not check the peripheral pulses. Make sure that you check the central pulses. Check the carotid pulse, check the femoral pulse. You count. If your pulse is less than 60, it means that this person definitely needs chest compressions because it's going to be inadequate to perfuse the rest of their body. So they need chest compressions to be started. You may consider giving them epinephrine. You're giving them 1 milligram of epinephrine as you're continuing your chest compressions. Again, if the pulse is 60 to 100 and they're not breathing, it means that there should be something with their airway. Often, how a patient is going to go through, if their heart stops, then they will also eventually stop breathing. If they stop breathing, eventually their heart will stop. So one way or another, the cardiovascular system and the respiratory system are closely related. So if your pulse is okay, then your patient is not responding, check that your patient is breathing. Check that there is some spontaneous respirations. If not, then you need to now contemplate whether you should start chest compressions and you should start bagging this patient. Then if the pulse is greater than 100, check the rhythm. Maybe this could be a tachyarrhythmia, maybe fibrillating, and you may never know. And all those things will have their different management, and the different rhythms have different management. If you have an AED, connect the AED. It will give you prompts on what is going to happen. If you connect your manual defibrillator, you look at the ECG tracing. I've done a video on cardiac arrest. I will leave it tagged at the end of this particular video that you can actually check out, which has these rhythms and what you simply do in this case. Then if there's no pulse, you would have to give them your epinephrine, start your chest compression. So you can see just on the vitals, there are a lot of things that you can do for your patient that could potentially save your patients. Then you come to check for the respirations. Is my patient breathing? If they're not breathing, you need to start ambu-bagging them. You need your BVM, your bag valve mask ventilation. So you need to start ventilating them. You give them your 2 rescue breaths. But before you do this, giving them your rescue breaths, make sure that their airway is clear. Because if you're giving rescue breaths and their airway is not clear, it means that you're wasting your energy. You're wasting your efforts. So clear the airway, which I do talk about in the next coming slide. So clear your airway. Once your airway is cleared, give your 2 rescue breaths. Continue assessing the patient. Continue bagging the patients. If you see that still they're not attaining this spontaneous respiration, then you should consider intubating that patient. If your patient is breathing, but you suspect that they have a secure airway, there's no compromise in the airway, then you can put this patient on oxygen. Monitor your saturations. Make sure that they're at least greater than 92%. If your patient is gasping, you're starting your bag valve ventilation. You start bagging the patient. This patient is the one that may need intubation. If your patient is breathing but the airway is not secure and you're worrying that your airway can collapse at any time, for example, this patient has inhalation or burns, this is ideally a patient that should be intubated quite early enough so that you put them on mechanical ventilation and you allow the airway to heal. And once that edema goes away and the healing has been quite adequate, you can extubate your patient. Then you're doing your ABCs, of course, after you've checked your vitals and you've made your decisions. So when those decisions on the previous slide that I was talking about, you're checking your vitals and you're making a decision there and then. You don't move on. If you see that the RBS hasn't been taken care of, you don't move on. If you see that the BPs are low, you don't move on from that. If you see that the saturations are low, make sure that that is being addressed at the same time as you are continuing to assess the patient. So you don't move from a specific thing until that particular thing has been assessed. Then you're obviously going to do your ABCs. If your patient now has fallen unconscious and they're not breathing, remember that there's a risk of their airway being compromised. So you have to do some certain maneuvers. You have to insert some certain airway adjuncts to prevent their airway from completely collapsing. Some of these you may have them on the ward, some of them you don't have them on the ward. But generally, position is everything. You want to position your patients because as long as your airway is compromised, even if your patient has a cervical injury, they will die. So it means that if they do have some sort of airway problem, then you should take care of that, and it's going to even take precedence over the possibility of a spinal injury. There are 2 maneuvers that you can perform to open up the airway. So the first thing is you're going to open the mouth. You can use what is known as a cross-finger technique. We'll discuss all these techniques when my paramedic actually visits or does a guest appearance on the channel. So one way in which this is done, you can do a cross finger. So it's like your fingers here crossing. It's like you're trying to snap. This thumb is pushing this downwards. This index finger is pushing this upwards to open the mouth like that. You open the mouth. Of course, positioning is everything. In the infants, you want to put a padding shoulder such that this opening of the external auditory meatus is sort of in line with the plane of the clavicle there, the sternum there. Then in the child, again, you put them in your neutral position, you put some padding underneath the shoulders. While in adults, you put them in the neutral position and you put the padding underneath their head. If they're obese, you just elevate the head end so that you can align the airways and they can be straight on like that. There are 2 maneuvers that you can do. You can perform what is known as a head lift, a head tilt, chin lift. So you have a head tilt and a chin lift. So the head is going to be tilted a bit and the neck here can actually even be supported whilst the chin is going to be lifted. Notice the technique here. The index finger and the thumb there is opening the mouth whilst you are tilting the head. There will be another arm here that is over the forehead like that, trying to open up the airway. This maneuver is not so good for those that have spinal injury, so we would actually advocate that you perform the jaw thrust instead, where you're holding on to the angle of the mandible. Your thumbs here are holding on to the mandible as well. They're opening the mouth whilst you are pulling the jaw upwards and you're tilting the head backwards. So a 3-step type of maneuver to open up the airway. This is a very good maneuver, especially for those that have spinal injury. You'd want to do this. And then if you are alone doing it, then there's a special type of technique. Even when you're bagging the patient and you're alone, there's a special type of technique that I will show you when we do the subsequent videos in terms of resuscitation. So you're going to be checking if your airway is patent. What are things that are giving you clues? Speak to the patient. Try and talk to them. Try and see if they're responsive. If they are talking, then most likely that the airway is not affected. But this is not always the case. So you're going to look, you're going to listen, you're going to feel. You'll look for any rising and falling of the chest. If the patient is spontaneously breathing, if air is moving in and out. You listen for any air movements. They say that generally in the primary survey, if you're doing a primary survey, there are no instruments, but in my opinion, you're trying to save the patient's life. So listen with your stethoscope. Then you'll be able to listen and feel for the air movements. If you hear any stridor, I did a video previously on lung sounds, so I think you can check that out. If you hear any stridor, which is going to be this musical high-pitched sound, this is going to be suggestive of an upper airway obstruction. If they're snoring, this is also another sign of obstruction. So make sure that you clear your airways with these maneuvers. And if there's paradoxical movement of the abdomen, also it suggests that there is a problem. Check for any foreign bodies. If they have any dentures, if the dentures are well-fitting and they're not loose, you can leave them there. If they're loose, you have to take them out. Assess your patient's GCS. If they're GCS, they're unconscious, they're less than 8, this is a patient ideally you want to intubate. Start calling anesthesia to come and intubate that patient. If their GCS is a bit high, but still they are have reduced levels of consciousness, you can consider putting an OPA, an oropharyngeal airway, which is one of the airway adjuncts, pushing an NGT for this patient, empty the stomach of this patient, put this patient on oxygen, make sure that their saturations are above 92%. And once you have done this and you are satisfied with your airway, now ask yourself, is my patient breathing? And if your patient is breathing, decide then what you're going to do. If the patient is not breathing, decide then what you're going to do. Remember, you've taken your vitals, you're assessing whether your patient is breathing, and you're combining whether your patient is breathing and the patient has vitals. There are different permutations that you can get, but the common ones are the ones that I've mentioned on your screen here. So you have your patient that is unresponsive, but they have a poor prognosis condition. That's the very first thing. You know that if you resuscitate this patient and you save this patient, you're saving them to what? There's no need for chest compressions here. The cornea, you check the cornea, there's no corneal reflex. The pupils are fixed and dilated. You just allow this patient to go. There's nothing that you're going to do. This is going to be a bit hard if the relatives are around and they see you doing nothing. So it's good practice to actually ask them to step out so that you can make such decisions. And afterwards, you can tell the news to the patient. The second permutation is that you could have a patient that is not breathing and they are bradycardic. They have a heart rate, but they are bradycardic. Here, it could be that maybe the reason why they're not breathing, that's what's causing their heart to stop. Because remember, if they have hypoxia, eventually your heart will arrest. So you want to start your bag valve mask ventilation, you ambu bagging. You start ambu bagging your patients. You lay the patients flat, you drop the bed, put them in, or rather straighten the airway with those maneuvers, the head tilt, chin lift, or the jaw thrust. Then give them 2 rescue breaths, assess, and your breaths must be adequate. You must see the chest rising and falling. In this case, because their heart rate is below 60, it's below the normal, you give them some adrenaline. You give them 1 milligram of adrenaline. You keep monitoring the pulse. You can start compression in this particular patients. In some case, we do give them hydrocortisone. We assume that there is some sort of adrenal insufficiency. It also helps with the cardiovascular support. We can give them hydrocortisone, about 200 milligrams as a start dose. Then if your patient is breathing, but their heart rate is less than 60, it means that they're bradycardic, they're breathing, you are just starting your chest compressions. You start your chest compressions, you give your patient adrenaline. Then if your patient, the fourth permutation is that your patient could not be breathing, but they have a normal heart rate. In this case, you keep ventilating your patients because as long as their heart is beating, they're pushing the blood to that area. But you're not going to keep ventilating the patient with a bag mask the bag valve mask ventilation. You'll want to also contemplate whether we should intubate this patient because they're not spontaneously breathing. You contemplate. So you start ventilating them, give them 2 rescue breaths and assess to see if they're going to have the spontaneous respirations. If they don't, you continue ventilating your patients. Make sure you don't overventilate them or underventilate them. If still there's no spontaneous breathing that's there, consider intubating your patients. Remember, you're still checking your vitals. And remember that checking of your pulse, checking whether your patient is breathing must not take more than 10 seconds for you to make that decision. Then you keep your adrenaline close because very, very, very soon your heart is going to stop. Then if your patient is unresponsive or if it's a patient that is gasping and their vitals are unrecordable, you're going to start your chest compressions, you're going to start your BVM ventilation, and you're going to give your patients adrenaline. So these are just the basic things that you're just going to be doing when you're called to the ward and your patient has deteriorated or changed condition. If it's in a specialty like obs and gyne, make sure that you check if your patient is bleeding from somewhere. Most likely, if they become hypotensive, they start gasping, their vitals become unrecordable, they are obviously bleeding from somewhere. So if they are coming in from post-op, check the incision site. Do a vaginal examination. Are they bleeding? Check the uterus. Is it contracted? If it's not, give them the oxytocin, remove the clots, evacuate the clots, give them some IV fluids. Then keep monitoring, massage the uterus. There is a way in which we resuscitate patients that is a bit different in obstetrics and gynecology. So now, what's our practical guide as to how we're going to be doing this? So remember, the first thing that you're doing is you're calling for help. Then you check your pulse, your respiration at the same time. Don't exceed 10 seconds. Someone is taking note of all the events that are happening. Someone is taking note of the time. You're also checking other vital signs, the RBS of the patient. If it's low, you treat. If it's high, you treat. Then you're also checking the temperature of the patient, all the vitals. Then you decide on whether your patient needs to be ventilated alone. They just need rescue breaths, or they need the ventilation and the chest compressions. If you're doing ventilations and chest compressions, generally one cycle is going to be 30 chest compressions and 2 rescue breaths. There's a song on YouTube that's known as Staying Alive. I'm not going to put it in the video because I may get copyrighted, but there's a song that you can actually Google that's known as Staying Alive. The rhythm of that song actually is how you should do your chest compression. So you push hard and you push fast. We shall do some videos on that, on how to do the effective chest compressions. And remember, you're doing them for 5 cycles, so 2 minutes. After every 2 minutes, you are reassessing your patients and seeing what you're going to do next. So you do your first 5 cycles. Then as this is happening, the defibrillator is being connected. Your AED is being connected to check whether it's a shockable rhythm or it's a non-shockable rhythm. If it's a shockable rhythm, give them a shock. If it's a biphasic device, give them 120 to 200 joules. If it's a monophasic, 360 joules. If you don't know, you can just put it at the maximum setting and give it to them. If it's not a shockable rhythm, you continue your chest compressions and your ventilations. You do another 5 cycles. You check again. Your patient still doesn't have a heart rate. They're not breathing. You give them adrenaline 1 milligram. You continue your chest compressions. Remember that your adrenaline can be given every 3 to 5 minutes. You again, after the next 2 minutes, you check the rhythm again. If it's shockable, you shock. If it's not, you continue to your chest compressions. In the case where we're on the ward where we don't have the defibrillator, you won't be checking your defibrillator. You continue your chest compression. And remember that there should be some minimal interruption in between these chest compressions. If still you're continuing, you've given your adrenaline, maybe this is the 3rd dose of adrenaline that you're giving, they are not responding, you may now consider giving them amiodarone. So if you're still unresponsive, amiodarone 300 milligrams is the first dose. You continue your chest compressions. Again, you check the rhythm after the next 2 minutes, after the next 5 cycles. If the rhythm is shockable, you shock. If they are non-shockable, you don't shock. Because remember that a non-shockable rhythm can easily convert to a shockable a shockable rhythm can convert to a non-shockable rhythm. Someone who had a shockable rhythm can now become a systolic. They have no activity. You continue your chest compression. Still, if this is not happening in the next 2 minutes, you consider giving them the 2nd dose of amiodarone, this time at half the dose. So remember here, what you're simply doing is your chest compressions, your ventilations, your adrenaline, your hydrocortisone in some cases we may even consider giving them atropine. But of course, I did talk about that in my cardiac arrest lecture, so you can watch that. And at all costs, you're going to treat the underlying cause. Make sure you address the underlying cause that cause this. And the maximum time limit that you can go, if you're doing effective chest compressions, you can go to about even 16 to about 24 minutes. But generally, for most people, by the time they hit 15 to 20 minutes, they would have stopped. So when do you know exactly when to stop? Previously, like I said, it was recommended that about 15 to 20 minutes after you're doing these effective chest compressions and rescue breaths, you can stop. But newer researchers can show that you can even go up to 38 minutes or even up to an hour. But once you bring the patient back, they're going to have significant neurologic deficits, and even the quality of life may be reduced. And these factors will depend on certain things: how old this patient is, the overall health status of this patient, how quickly did you notice that this patient has become unresponsive, how much quality of the CPR was being given. But in most studies, they actually came to the conclusion of about 16 to 24 minutes after you witness the cardiac arrest. If still you're doing your effective chest compressions and your rescue breaths, you're resuscitating your patients effectively, then if you're not responding, stop after this, because the quality of life will not be so good. You're going to cause the patient to be alive but brain dead. And the last thing is that you may now have resuscitated your patient and they have regained what is known as return of spontaneous circulation, what we call ROSC. They have gotten back. If they were hypoglycemic, you gave them dextrose and they're okay. If they were hypotensive, you bolus them with the fluid, you notice the BPs are rising, you continued giving the fluids, they are okay. If their heart had stopped or they're not breathing, you ventilated them or you started them on chest compressions, they come back and they're okay. You have to address what was underlying. You have to address certain things that could potentially cause your patient to arrest, what we call the H's and the T's. So the things that you want to consider are things like hypovolemia, continue them on the IV fluids, contemplate whether you should start them on inotropes or vasopressors like dobutamine, dopamine, adrenaline. If they were hypoxic, give them oxygen. You may consider intubating your patients and performing mechanical ventilation. If they're hypoglycemic, 50% dextrose, followed by maintenance of 10% and 15% and 5%. If they're hypothermic, keep them warm. Correct any hypoglycemia because they tend to occur as a triad. Hypothermia, hypoglycemia, and infections. Treat those things. If they have acidosis, which are hydrogen ions, which are a lot, consider giving them bicarbonate therapy. But of course, whatever is causing the acidosis, if it's corrected, for example, in a DKA, then the acidosis itself may correct, unless if it's refractory acidosis. Then if they're hyper or hypokalemia, manage them as indicated. I've talked about this countless number of times on the channel. If it's a tension pneumothorax, perform your needle decompression. Put an ICD. If there are toxins that are there, clear those toxins. If they have swallowed the poison, if the gastric lavage is indicated, perform a gastric lavage. If it's activated charcoal, give them activated charcoal. If it's an antidote, for example, if it's organophosphate poisoning, you're going to be giving them your atropine. Is the atropine protocol that we use. If it's thrombosis, an acute coronary syndrome or a PE, thrombolytics. If it's a cardiac tamponade, you want to perform your ultrasound guided pericardiocentesis. You want to address all these things because they could potentially cause your patient to arrest again. So what are some of the things that you should look forward to on the channel that are coming? We're going to do videos on chest compression, proper technique, how to perform our bag valve mask ventilation, the proper technique. We're going to talk about intubation. We're also going to have a basic life support videos. We're also going to have advanced cardiac life support videos. If you enjoyed these videos, consider subscribing to the channel, hit the bell notification icon so that you never miss on such amazing content every time I post. To Zambia and beyond, my name is Dr. Moses Kazevu. Until next time, bye-bye.